practice, and that is the acute coronary syndromes. And we know, at least from the histological sudden cardiac death studies from Renu Virmani's group, that 60 to 70% of these are from those thin-capped fibrous atheromas that rupture. Then the inflammatory-celled fibrillar atherosclerotic plaques with a lot of surface inflammatory cells, where the surface gets denuded and we get plaque erosion, about 20 to 35%, and the 5% which is a calcified nodule. And we can see all of these with OCT. Here are some features that are associated with plaque vulnerability and plaque rupture. So that's a thin-capped fibrillar atheroma, little macrophages with the shadowing, big lipid-rich plaque, spotty calcification is microchannels or vasa vasorum, and cholesterol crystals. And we have also now seen from large registries, and the MGH registry was one of the largest, where we see what happens when you actually get an acute coronary syndrome. And here we have two examples of plaque erosion where the surface isn't disrupted in this fibroatheroma, but you get thrombus on top of the surface. And if you image these in about a month's time, you get a nicely healed plaque with no surface disruption. This is a typical thin-capped fibrous atheroma which has ruptured, and the necrotic core is now in contact with the blood, and that's when you get a STEMI. And there you get this protruding calcified nodule. There are various algorithms, which in the interest of time I won't go into, to tell you, how you can define all of these with plaque rupture, calcified nodules, erosion, and of course others like SCAD. You can also see thrombus, which sometimes is clinically important. You have a stent which keeps clotting, and if it looks like it's red thrombus or white thrombus, you can then decide, do you want a 2B3 inhibitor or do you have to give more heparin? So white thrombus is high backscatter, which is bright, and low attenuation, so it's bright throughout. Red thrombus is again high backscatter, so the surface is bright, and you will remember, but high attenuation, so it gets dark. And these are a couple of examples of red thrombus. Surface is bright, but deeply here it's dark. And white thrombus, this is a ball of little platelet-rich thrombus. It's bright throughout. And then a few other scenarios of recanalized thrombus and SCAD. Recanalization, this is a figure of an LAD, a picture of an LAD, which angiographically looks like it's probably recanalized. And when we do OCT, you get this, what now called honeycomb appearance. Very similar to what you see in histology. And this is pathognomonic of recanalization. SCAD, spontaneous coronary dissection, is exquisitely seen with OCT. You can see the intramural hematomas, causing luminal compression. You can see the intimal tears, the entry site. You can see the hematomas where there's a bit of contrast in them, what it looks like after stenting, and whether your wire is extra luminal, and in this case it is. Dissections are very anxiety-provoking. They could be edge or intrastent or just after a balloon. You have a flap, a cavity, a double lumen with a hematoma. There have been various definitions as to how long it is, how deep it is, what extent it is. These are all very interesting in the context of following up on. Here's one of a really large edge dissection that you can see. You can see the stent finishes here and this dissection here. Ultimately, most of these will heal up. So the bottom line with all of these is that you see it not uncommonly. They often don't have any clinical consequence, and you mostly will treat on the basis of angiography, not on the OCT appearance. I'm not going to talk too much about stenting because we've got most talks relating in particular to that. But you can, with the resolution, look at stent starch coverage if you're following someone up post a stent. An embedded stent with nice coverage where it's flat and linear along with the vessel wall. A protruding stent where it's protruding but still has a bit of covering. The protruding stent which is uncovered, and a malapose stent. So various nomenclatures of stents. Moving as we progress and the longer the stent is placed, there is neointimal hyperplasia. And there are various forms of neointimal hyperplasia, 3 in particular. The homogeneous one, where it's all of one homogeneous and the tissue looks the same. Layered, where the deeper layer is often very vascular and much darker. These suggest a very high inflammatory response, often very early restenosis. And of course heterogeneous, where there's a whole mixture of stuff. These two are particularly vulnerable to significant restenosis and new atherosclerosis. And of course then we know with OCT we can see neoatherosclerosis very well. So everything you've learned of plaque characteristics that we talked about a few minutes ago, you can see within your stent. So here you can see little microvessels. You can see here between about 1 o'clock and 4 o'clock on the side, microchannels. Here you can see, that's your stent there, a thin cap fibrous atheroma. Here in fact a plaque rupture within a stent. Calcification underneath stent struts. Red thrombus within a stent, bright on top, dark as it goes down. White thrombus up here. So we're out of time, so just how to be comfortable with OCT image interpretation. The first thing is you need to do more cases and see a lot. Review your cases carefully, not just the axial sections, look through the entire run. There are plenty of resources to look at, review articles, books, e-resources, and the important thing is to get involved, like in a program like IPCI, share cases, discuss cases. I will often get cases, even from my friends and colleagues in India, on my WhatsApp, where what do you think about this? And I will do the same to them, and that's really the way you learn. Thank you.